Hi, everyone. Welcome to our webinar today. We have a few of you that are joining and we'll continue to admit people as they come in. Just giving you a minute to get your microphones and your cameras connected. Before we start, just a reminder to you to please keep your microphone muted so there's no background noise from our environments. And I'll just give you maybe one more second to connect to audio so you can hear me. All right, welcome to our webinar today. This webinar is on answering the top 10 questions related to LSVT Big and LSVT Loud treatment, brought to you by LSVT Global. So we actually have a team of panelists today that will be answering these top 10 questions. I myself will serve as the moderator today. My name is Laura Gousset. I'm a physical therapist and one of the LSVT Big faculty. And I'm joined by my colleagues, Bernie Kozer, also an LSVT Big faculty, who's an OT, Heather Ciance, who's a physical therapist and LSVT Big faculty, Dr. Jessica Galgano, who's a speech language pathologist and one of the LSVT Loud faculty, and Dr. Cynthia Fox, who's our CEO of LSVT Global, and she serves as faculty for both LSVT Loud and LSVT Big. So thank you all for joining us today in the middle of a Wednesday afternoon where we're from. Maybe it's morning for you or maybe it's evening, depending on where you're joining us from. But we welcome you and thank you all for joining us today. I won't go through our biographies, but if you are a physical therapist, a speech language pathologist, or occupational therapist joining us, you'll be sure to want to save your handout that has these bios listed in case you need it for CE reporting. In brief, we are all expert clinicians in providing LSVT Loud and LSVT Big in our specific disciplines. So we're really excited to share with you some clinical pearls of wisdom that we've learned over the years as treating clinicians. And we hope that this information is helpful to you as well. So some brief disclosures. We have both financial and non-financial relationships with LSVT Global, including a treatment preference for LSVT Loud and LSVT Big. And financially, I myself, an employee of LSVT Global. Dr. Cynthia Fox is a owner of LSVT Global, and we receive consulting fees and lecture honorarium for our webinars. So again, welcome to you, all of you that are joining us today. You've joined just in time. During this webinar, the majority of time will be spent answering these top 10 frequently asked questions. And these are really questions that have come to us over the years, that these are ones that we get asked time and time again. So we know that for many of you, there are questions that you have, and we are happy to provide the answers. In terms of logistics, please make sure that your microphones stay muted during the webinar so that there's no background noise from your environments. Cameras are totally optional. We'd love to see your faces, so feel free to leave your camera on, but if you'd rather go incognito, that's totally okay with us too. The majority of the time will be spent presenting the content. This webinar is being recorded. So if you want to go back and listen to it or share it with a colleague or a patient in the future, this will be available in the on-demand webinar section of our blog, which is blog.lsvtglobal.com. If you have questions related to these frequently asked questions or you think of others, please type them in the chat box at any time. We'll answer as many of those as we can during this hour. And if there's remaining questions that we didn't get to, we will be sure to follow up with you via email. You can also email us anytime at info@lsvtglobal.com with your questions, and we'll direct them to one of our clinical experts. After this webinar is over, you'll be emailed a link to fill out a survey. It might not come today, but probably this week you'll get an email from us. So be sure to look for that. And it's really short, should take you only 5 minutes, and we always appreciate your responses. In terms of CE information, we know that some of you that are joining us today are therapists and want to know, can you report this. So just so you know, LSVT Global webinars are not ASHA or state registered, so they're not pre-approved for CE credit. But if you would like to, we can email you a certificate that will have the name of the webinar, the date, and the duration of the webinar so that you can use that for self-report. You do have to attend the full hour to be able to claim that 1 hour CE credit. If you're not sure about your state requirements and whether they accept self-reported CE activity, the best thing to do is to check your State Practice Act and contact your board. So I won't go through these learning objectives one by one, but I'll let you take a look at them on the screen, and they directly relate to the top 10 FAQs that we will be addressing in our presentation today. So with that, I'm going to stop sharing my screen, and you should be able to see all of our panelists in big screen right now. So thank you for joining us. And I think we'll just get right to work. These questions are not necessarily in any specific order of importance or anything like that. So we're just going to dig in. And for those of you that are joining us, if it prompts more questions related to that topic, please don't hesitate to type in your question into the chat box. Maybe you have a related question or need some clarification about what we said. So we'll be monitoring that chat box throughout, and please feel free to use it. Okay, so one of the biggest questions that we get, not only from therapists who are not yet trained in LSVT, but also from patients and family members, is just like, what does big and loud actually mean? And more importantly, what doesn't it mean? Are there some misconceptions that are related to those terms, which are part of the treatment names? So Jessica, I'd love to start with you. And, what does that mean and not mean to you as a speech language pathologist, that word loud?
So what loud means to me is normal loudness. It is nothing more. When we hear that term loud, we think loud like this, because in our typically developing or functioning system, when we are producing voice, we have normal loudness. And when we increase our effort, we get loud like this. So, but in LSVT loud, what loud means is and in the LSVT loud, what loud means is normal loudness. For individuals with Parkinson's disease, hypokinesia, or a reduced amplitude of movement, is a very common characteristic or underlying issue that people struggle with. And what results is lower volume, or reduced loudness. So that person with Parkinson's will feel loud when they reach normal loudness levels. So to me, loud is normal loudness or producing voice with normal amplitude. Though that person with Parkinson's, when they produce voice with normal volume, they're going to feel loud. Because for their whole life, when they increased effort levels, what came out was a loud voice. But now with reduced amplitude of movement, when they increase their effort, they feel loud, even though they're just reaching those beautiful normal loudness levels.
Excellent. So I have a question for you. I'm a physical therapist. Do you have it from time to time where your patients actually feel like they're shouting when in essence it's perfectly at a normal level?
Always, always. And that one of the reasons for that is that the issue for people with Parkinson's is not just motoric, it's sensory as well. And so people will feel like they are speaking normally. They don't necessarily always realize that that amplitude of movement has reduced and they've become quieter. So it's not always easy for that person to tell that they're a little quieter than they normally were. And when when they increase these effort levels, they frequently feel like they're yelling. And that's part of the therapy, is with practice and with the treatment, that feeling, you get used to it, and that resolves, and that feels like your new normal. So you can reach those normal volumes. But yes, it's very, very common.
Awesome. And Heather, as a physical therapist, do you find the same parallel, the same analogy in movement? And what does that look like?
Yes, Laura, absolutely. So just like Jessica said, loud actually means the normal volume. Big actually means getting people with Parkinson's to move at their normal amplitude of movement or their normal speed of movement. And folks with Parkinson's disease, because of the slowness of movement, the smallness of movement, as well as some of the cognitive issues that go on with their ability to kind of understand what's going on within them, sensory processing, being able to feel how the body is moving, to kind of feel where the body is in space. All of those things kind of take away from their ability to feel what their actual movement is like. So we as physical or occupational therapists come along and we say, wow, you're sitting with really small posture. You're talking very quietly. We need you to make everything big to actually make it feel normal. And they'll say to me all of the times, I can't walk around like this. I can't take this big of a
Yeah.
step. I live in a very small house. I couldn't, if I stand up this tall, I'm going to fall backward. And it's that whole
Yeah.
misperception of what they are feeling and how they're actually moving, where using the phrase big, meaning we want big effort, we want big movement, we want big communication, we want just a bigger life for people, is really where we come in and do that. So yeah, the LSVT loud and LSVT big, those patients that are going through both, very similar in their kind of misperception that they're doing too much bigness and too much loudness, where we're actually putting them back into that quote unquote normal place that they need to be in.
And maybe both of you could answer this. Does it ever feel normal to them again, or does it always feel like they're moving too big or talking too loud?
So it's a little bit dependent on the patient themselves. I would tend to say in my practice, if I'm working with someone who is a young onset patient or someone who's newly diagnosed, it tends to feel pretty normal pretty quickly. We can really get them to understand that that much effort is what they need. Sometimes with your folks who are in the later stages of the disease, it still feels like it's a lot of effort for them, but they accept that this is the effort that I need so that I can walk across the room. This is the effort that I need so that I can get out of that chair. So again, it's going to differ patient to patient, but again, I think in those earlier stages, it becomes more of the normal accepted feeling, and it feels normal to them.
Mm-hmm.
And I would agree.
Same with you.
Yeah.
Yeah. Okay. All right. This next question, number 2, is maybe a little bit related. I have a feeling, just a feeling. So, the question that we get oftentimes from therapists is this: it seems like such a simple concept, like, think big or think loud. It's not rocket science. I already work on amplitude of movement, I already work on louder voice in my typical PT/OT speech practice. But on the other hand, my patients struggle, right? They're not carrying over from session to session. I'm training amplitude in my therapy practice, but they're not carrying over from session to session. As soon as they walk out the door, it's back to their low levels again. So, like, what am I doing wrong? And how can I address that? And this is obviously something that we go over in the LSVT training. But Jessica, why don't you kick that question off?
Absolutely. Well, there's so many different things that we can do. And I think as therapists, we have to be very flexible and creative in the activities that we choose and the materials that we choose for each individual that we're working with. Typically, there are a number of things that we can do to make sure we're maintaining those treatment effects and allowing or facilitating carryover and long-term outcome. And one of those things is establishing and really staying adherent to that daily home exercise program. In therapy, each therapist, whether an LSVT big therapist or an LSVT loud therapist, one of our jobs is to really help individuals establish a very regular, consistent daily home exercise program, because it's that daily practice that people will continue with once that intensive program has been completed. And that is so important to help them maintain treatment effects. So a strong home exercise program people adhere to every day is key. But then also what's important during therapy is adding what are called dual tasks and cognitively loaded exercises or exercises that, for me, when we're working on loudness, might also bring in movement or a functional activity that is very similar to what someone would be doing in their day-to-day lives. And so, for example, if I work with a woman who's constantly trying to find things in this very huge tote bag that she carries around. And she's always got her head in her bag looking for something as she's trying to tell her husband something. And her husband always complains he can't hear her when she's doing this. And so one of the activities that we work on while we're focusing on loudness with great clarity is searching for her keys in her bag or her wallet or something like that. And adding these additional motor tasks to the loud practice, adding activities that make someone think while they're talking and maintain that loudness while they're thinking, while they're doing, while they're moving. All of these activities can really help create those stronger neuroplastic changes at the level of the brain that we've seen with all of the research that's been done. And what that results in is a nice, more automatic regular use of loud voice or possibly big movement in their day-to-day lives. So adding those cognitive and dual motor tasks to the therapy as someone's gaining strength is very important to help people not just have fun, but really bring that loudness more easily into their day-to-day activities. I would say one more thing is taking part in a maintenance group. You know, we have these great LSVT Loud for Life groups, and they're so much fun. They're great for socialization and making sure you're keeping up on your exercises. And what's really nice about them as well, besides the fact that you're socializing during this time of isolation, which is so important, it's that you're not just hearing from your therapist that you're not moving too big or you don't sound too loud. You're hearing from people who are just participants in your group who may be going through similar things. And you're hearing from those individuals that you do sound fine and you sound great, actually, and you don't sound too loud. So those groups are also really important for helping to reinforce those changes and those increased effort levels that you're using, and just kind of puts you in the right place to make sure that you stay strong, you're able to produce these bigger movements, this louder voice that's normally loud, and you don't feel you feel comfortable doing it. So those are some great ways to maintain, to establish long-term outcomes and keep them.
That's awesome. Yeah, I think you answered like 5 questions in one there. That was great, Jessica. That was like 3 good answers there. And we'll expand a little bit more on the maintenance part because it's so critical, like you said. I love your example about the woman digging in her purse, and I think as therapists, we always got to be thinking about how can I make this relevant and meaningful to my patient. You hit on the home exercise program importance too. But one of the things, and maybe I'll toss this to Bernie, is in our previous question, we talked a little bit about this weird sensory deficit that people with PD have. Do you see that also? You're an OT. Do you see that also as a barrier to being able to carry over bigger movements into function if it feels weird to them?
Yes, it's an enormous barrier. Again, my background is as an OT and in home health. And I remember working with patients in the home. This was pre-big and post-big, learning big, that is, working with them and just not seeing that they weren't able to make that connection until we were able to incorporate a little bit more time, repetition, cueing, the feedback that Jessica was talking about from the family members, from other therapists, other nurses on the case. So yes, I think that it's that sensory mismatch that's so difficult really to understand. When you first started talking about this, we were talking about how, sometimes people think, oh, it's just, you cue your patient to be bigger or louder, but it's more than that, because I was thinking about this, it's the patient who's so much more complex. There's so many more deficits or so many more barriers there that they are having to overcome. It's so hard for them to get that connection. And so it's up to us to really use our techniques, our training, our redundancy, our connection to function to help them to move big on a more day-to-day basis. So absolutely, it was something that we saw all the time. It was maybe, I haven't seen somebody pawing through their purse like that, but I've seen people just struggling with some of the basic ADLs for sure.
Thanks, Bernie.
Yeah.
All right, let's move on to question number 3. And I'm going to pose this one to both Heather and actually Cynthia. Oftentimes, our goal, our dream as therapists is to get people into therapy early, is ideally, soon after they're diagnosed, optimized on their medications. We like to see them in for therapy. However, we hear from therapists like, do they really need 16 visits of LSVT big and LSVT loud when their voice or the movement deficits are really actually subtle, oftentimes well managed with their medication? So what's the rationale there? And Heather, I'd like to start with you.
Yeah, it's a great question. And we get that all of the time, even from the patients, who the patients say, well, why would I need this much therapy early on? Number one, we're talking about a chronic progressive neurological condition. We know generally the course of what's going to happen with most people, right? We know what the symptoms are. We know about the non-motor symptoms, the motor symptoms. And there's a point in which if we wait too long, things become more challenging. So we're of the theory, use a word at our clinic, prehabilitation. Let's start with people now, fix those subtle things, because a subtle thing in Parkinson's does not remain subtle very long. It's very easy for things to change. If they have another comorbidity, they have another illness, something else happens. So I always say to therapists who are unsure about this, you need to challenge yourself as a clinician to really look. Some of those things aren't really so subtle. Some of the things we just don't know how to look for them or where to find them. And I think when we do something like Jessica was talking about with dual tasking, when you make the challenging or maybe even the simple situation more challenging, you will see that people will lose amplitude, they will lose volume. When you kind of overtask their system, which is something that's going to happen, especially if you're somebody who is newly diagnosed, still working, you're managing a home, a family, a job, many, many things. It's important to say, hey, if we start now, we are going to be able to kind of slow this down. We're going to prep you for the changes that are coming up. And a lot of times with Parkinson's disease, just keeping things how they are, right? Once you fix them and keep them there, and you get that person on that good home exercise program, even when they're done, when they come back to you and there's hardly any changes, you've done a great job. As opposed to people who have started therapy much too late, in my opinion, have already started to have the falls, have already lost the voice volume, all of those things. I'm under the belief that there is always something we can do for these folks. We just need to be able to use the right outcome measurement tools and to be able to ask the right questions to find out what the deficits are. Because the motor sensory disconnect doesn't start when they're in stage 3. It's already started before they've been diagnosed, right? They haven't been swinging the arm for how long? People have been asking them, could you say that again for me? So these deficits really do run quite deep, and there's really no time like right at diagnosis to start.
Good points. Good points. And Cynthia, how about you? Like, if someone says to you, well, why not 8 visits or 12 visits? What do we say?
Right. Well, because it is well, first of all, when patients say, I'm pretty well managed, I don't have any problems, they have a diagnosis of Parkinson's, which means that got them to the doctor, there are problems there. And even if the medications are managing, they're typically not managing everything. And that's part of our assessment, to dig in and find out where are the deficits. And I always think of one great example of a woman, she was early Parkinson's, working full time, a physician, she's my patients can hear me, things like this. We dug a little deeper, and she said, well, yeah, when I get home, I'm done. I'm spent. I don't want to talk to anybody. I don't want to talk to my kids, my husband. I gave it all, and now I have nothing left. And that's a perfect example of a whole part of her life that's so important: communication, home, family. She shuts down because yes, she could do what she had to do at that moment, but what we can do with therapy is give her techniques, give her endurance, give her lasting power, things she did before Parkinson's disease. So you've got to think bigger and wider. The reason even early it takes intensive treatment, because again, it's progressive neurological disorder. It's a complex sensory motor problem. There's a central sensory processing deficit that we have to treat intensively, directly and comprehensively. And that's really a distinguishing feature, I think, of LSVT LAD and LSVT BIG from other therapies, is we go after the sensory problem, even more importantly in some cases than the motor problem, to make changes that really last over time.
Awesome, thank you. And I think I can speak for all of you who have provided treatment to patients for years, even early PD patients, that it takes all of those 16 visits to truly get them to have it stick. So it's in their brain, it's carrying over, it's generalizing. Yeah, okay, let's move on to the next question here. Okay, what if my patient can't come to outpatient therapy 4 times a week? Many reasons, possible for this. Could be transportation issues. It could be their schedule, their work schedule. Maybe they just don't see the rationale, the necessity for it. Lots of different reasons that might be difficult for them. But what are some of the options for patients like that? And what's the discussion that you typically have with them related to that? Heather, can you start with that one?
So I always like to say, amongst all of the horrible things that have happened with COVID, the one wonderful thing that it has opened up for us as therapists is telehealth. And that has been a tremendous gain for us in the world of PT and OT, to be able to provide that for people. I know some SLPs have been able to do that for a while. So for us, if it's for people who can't leave the home, people who can't drive, people who don't have transportation, those kinds of things, we can certainly provide this in that means. In my practice, it's been amazing the people who have said, I've been wanting to come to you guys for years, but it was too hard for me to get there. And now we're capturing people from a much larger geographical area. So that's one plus. One of the other things for people who are able to come in and I talk to them about it, I instruct them and educate them about what it is, I always say to them, give me 1 week, give me 1 week. Let me do what we call stimulability. Let me see you for those 4 sessions. And I can pretty much promise you that you're going to see a change. You're going to feel a change. Other people are going to notice a change, and you're going to really believe it now. It's one thing to kind of tell people about it, but it's another thing to show them and have them experience it. So it is the rare patient who starts with me and does not finish with me after we have them. So I think the proof is in the pudding.
Yeah, that's awesome. And I think, Heather, you've probably had patients like me too, who you get to the end of this intensive month of treatment, 16 visits, and they say, please I don't want to stop. I want to keep going. They enjoy coming to therapy.
Yeah.
Jessica, is there anything else that you want to add to that? Any pearls of wisdom from your clinical practice?
No, I think as Heather mentioned, as speech pathologists, we've been lucky to have practiced with telehealth for many years. And what's wonderful is that LSVT Loud or LSVT Loud via telepractice has actually been around for over a decade. And so it was very easy for us to transition to fully online. And we actually do a combination. In pandemic, we were all online, but you know, we can do a combination of online, in home, out in the community, in the office, to really help people establish that generalization. But LSVT Loud via telepractice has been very easy. And what's wonderful is that there is a lot of research to support its efficacy online. And what's so great is that as speech pathologists, we don't have to hope or question that this is an effective therapy program that's available for people online. This is actually one that's been studied and has been proven to be effective with this same outcomes that you can achieve in that face-to-face therapy. So there's already that confidence that you're going to have the same outcomes, and you do. It's great.
Awesome. Awesome. So where can someone go to learn more about LSVT, Loud, and telehealth if they are interested in knowing more about that?
Well, I think one of the best places is the LSVT Global website, www.lsvtglobal.com. There is so much information, so many videos, so many pre and post videos, and there's so much great digestible information, not just about LSVT Loud, but big as well. So I would think the website, these webinars that are available for the public each month, and I would say those are kind of the two best places to go for information and just some not hands-on, but the ability to see some
Yeah.
of the videos of people pre and post.
Okay. And Cynthia, do they need a special certification if they want to do LSVT Loud via telehealth?
We do have LSVT eLoud clinicians, and we have a 2-hour webinar. So you take the LSVT Loud training and certification course, you learn the treatment. And then we have a 2-hour course that you can add as an addition. And it really walks you through the nuts and bolts of the mechanics of delivering LSVT Loud via telepractice, from data collection, assessment, sharing materials, all those reimbursement, how to get an ENT clearance, all those nuts and bolts. And anybody who's completed that is listed as an eLoud provider on our clinician data search. So if you're specifically looking for somebody who is offering LSVT Loud via telepractice, that is how you can locate them.
Excellent. And I can speak to the LSVT big part. We're really in our infancy right now of providing LSVT big via telehealth, but it is possible. And like Heather said, it's one of the silver linings of the COVID pandemic, if you want to call it that, is that it spurred us on to do that. It's opened up the availability to do that through Medicare in the United States. And I know the same thing is happening in some other countries as well. So this time, if you get certified in LSVT Big, you'll have access to some webinars that will talk to you just about some of the basic things to consider when you're doing telehealth for clients that have LSVT Big. And then, of course, our APTA and AOTA in the US have really wonderful resources for clinicians that are looking to dive into telehealth. All right, Bernie, I want to talk to you, and this is kind of related a little bit to our last question. You have spent many years in your career in the home health arena, but I also know there's a growing movement towards mobile practices in the United States where people will actually go out to your home, even if you're not a homebound client, and it could be billed under Medicare Part B. And I see that as a really nice option for people that really do have difficult transportation issues. Maybe telehealth really isn't a feasible possibility for them as well. Can you talk to us a little bit about that and what you've seen?
What I've seen has been a real kind of resurgence. It's really kind of blossoming a little bit more, at least in our area. I'm in Michigan, and until now, we didn't have too much Part B in the home. I did it personally as a Part B LSVT big clinician, and I did it jointly with a physical therapist who worked in the clinic while I went out to the patient's home and was able to carry over a lot of the functional components right in the patient's home environment. It was really awesome. So I'd say it's almost like the best of both worlds, isn't it? I mean, you're getting patients who really have, you know, the kind of the intensity ability. They're out in the community. Truthfully, we'll talk about, I'm sure, home health in a moment, but home health is very restricted. You have to be in a patient's home. Patient has to be documented as homebound, or at least right now under the COVID emergency waivers. But Part B and the outpatient in the home really gives you a lot more flexibility, so that you're able to see a patient in their home environment and be able to take it into the community. Now, I actually, in my practice, I would take patients into fitness gyms, you know, to carry over some of their home exercise programs in the gyms, or I would take them into the stores and out into the community. So you really had a lot more options there. I think that people are really seeing that as not only feasible, but maybe even profitable in some ways. So I'm seeing the business end of it catching up to what we knew already intuitively as therapists and as LSVT big therapists.
Mm-hmm.
Yeah.
I love that. And I love the ability to do in-context training for both voice and movement, to really see the patient in their environment, work on those barriers directly, I think is fabulous.
So strong. Yeah.
Okay, I'm going to keep you on the hook for the next question. All right, so we talked about being in the home during Part B, billed as an outpatient. And for all of our international friends listening, I apologize because I know this is kind of US specific right now, but I think there's some things that are applicable across the board.
Yeah.
So, you know, everyone knows about this dosage of LSVT loud and LSVT big of 16 visits. We know that there's been a lot of changes in our regulation and payment through Medicare that started a year ago, actually, to date. So we get questions from therapists like, you know, how do I do this profitably under Part A? What's the conversation that I can have with my manager? I see the clinical benefit of doing this for my patients, but I'm not sure how to make it happen. So what are some ideas or strategies that we can use to still help our patients through the LSVT protocols?
Well, first, I want to get on my soapbox about these patients. They are so in need. They are so in need. We totally have to advocate for them to find a way. These are patients who are kind of rusting away at home. And so they are the frail patients, the ones who are most vulnerable, not just to COVID right now, but vulnerable to maybe being moved into a next level of care. So we have some real opportunities. These are patients who usually come to us based on some other kind of medical issue. But then we see them as a therapist, and we see that according to our evaluation that they would benefit from LSVT big and LSVT loud. Now, what we're hearing though from our clinical managers and from our home health agencies is that there is restrictions on the number of visits that you can do. And, you know, I think this is something that all parts of the continuum have dealt with in different ways, outpatient to and inpatient, now to home health. Home health is dealing with something new. It's called the PDGM system, which is patient-driven groupings model. And that all it means is that Medicare has been collecting claims data, and other payers, they've been collecting claims data on your patients and saying, well, you know, this patient, they have, you know, this kind of problem, or they have this type of a clinical scenario, and this is how much they've typically been paid in the past, and that's how much we're going to pay a home care agency for those 30 days for it. And then the following 30 days, we're going to reduce the payments a little bit. We're going to change it up a little bit because most patients are discharged from home health within 30 days, and they may move on to another level of care, or they are already discharged into the community. So the thing is, I think that there's a real misconception here that there's actually a limitation by Medicare on the number of therapy visits. There is not. In the past, therapy was a driver of reimbursement for home health agencies, so they made money. And now they are a cost. So they have to be factored in, just like wound care supplies or anything else has to be factored in. So that's your job as a therapist. First off, your job as a therapist is to do the best for your patient that you can, and to advocate for them in whatever way you can, right? We all know that. So you have an opportunity here to advocate for your patient to be able to be seen for LSVT loud, LSVT big, based on your evaluation. First off, your evaluation supports the patient's functional classification, and that translates into dollars in the PDGM system. And your evaluation also contributes to information about the patient's comorbidities. Comorbidities also are coded in and they add to the dollars. So these are important things that you have to think about as a clinician, is to make sure that you're doing a thorough evaluation, uncovering the deficits. A lot of times things like fall risk are not really carefully addressed. They might be addressed in a very, very simple way with a timed up and go that maybe a nurse might do as part of their start of care, but you have greater tools and you can provide more information. You can uncover the deficits by pushing your patient, by doing the stimulability test, where your nurse or whoever has done the start of care has not. So you can provide that information to them. So take this information back to your clinical manager. Give them the information about how there's more to this patient. This is typically they fall into the rehab, the MS rehab clinical groupings. It's a certain amount of money, but that money is meant to be used for therapy. So use it wherever you can use it. If you have an agency that gives you a lot of rigidity, that gives you just a couple of visits that you need to see a patient for, you have to start thinking outside the box. You're going to have to think about the bridge to the next care level. You're going to have to reach out and create some kind of grassroots system if you don't have a hospital system already at your disposal, or a health system at your disposal, where you have a continuum of big and loud certified clinicians. You want to reach out and create those so that your patients will have a smooth transition into and bridge over into another segment of the continuum. I don't know if you were going to talk about that later, but just, that it makes sense. Our goal always is to advocate. I don't see many of those kind of continuums created right now. It feels like everybody's just kind of going, oh, well, I can't see the patient. I can't do LSVT loud. I can't do LSVT big. That is not true. That is not true. It's something that you have to maybe do a little differently, but there's always a possibility that you can help your patient to use a very efficacious treatment in some way.
Excellent. So last question related to that. Can you clarify what you mean by bridge to continuum? Does that mean that they start in one place, and what does that mean?
That means that you can either be the receiving setting. Let's say that I'm receiving a patient in home health who came to me from a skilled nursing facility where a LSVT big or LSVT loud certified clinician assessed the patient, started the program, or maybe just did some stimulability testing, and then contacted me, because of course we have such a smooth transition of care between one setting and the other. But anyway, that's the goal. So you have an excellent transition of care. Ideally, you're going to be picking up the phone and talking with one another. I, as a home health OT receiving the patient for LSVT big, would want to talk to whoever had them first. And then perhaps it goes the other way. Maybe it's a bridge to outpatient, or even to the outpatient in the home type of a setting. Patient is no longer homebound. I've done some magic. The patient is no longer homebound, and I can move them.
Yeah, that'd be a great outcome.
It could happen. Yes.
All right. Thank you. It does happen. That's right. That's right. Okay, good. Heather, I'm going to kick this next question off to you. So you and I are both physical therapists, but I'm guessing that this happens in OT and speech as well, that we take pride in our ability to be creative and think outside the box, and we get a little defensive when we hear the word protocol, and how is LSVT big going to be fun? How am I going to use my creativity skills with such a quote unquote rigid protocol? And we've heard that quote before. Now you and I both know the answer to this, but I'd like to hear it straight from the horse's mouth here. What do you say? What do you think?
It is not rigid at all. Get the rigidity out of your mind. The only thing that's rigid are your patients, okay? What we have is a fundamentally well-researched program that is based on the main problems that our patients have, the bradykinesia, the hypokinesia, hypophonia, all of those things, where we retrain that motor sensory deficit. We have, yes, 7 exercises that all patients will do. But guess what? Patient A does them differently than patient B, does them differently from patient C. Some people do them in standing, some people do them in sitting, some people need me to cue them the whole time, some people need a care partner to be with them. Then when you move into, at least with LSVT big, your functional components, your hierarchies, those are all individually mandated by you and the patient. you do your evaluation, you ask your patient, what are the functional problems you're having? What's it like for you to get in and out of bed? How many times do you have to get up in the middle of the night? Are you able to dress yourself? What's it like to get in and out of a car? You know, I have trouble getting my wallet out of my back pocket. The patient tells you what difficulties they're having. You then tailor your program around that patient's needs. It's as simple as that. So that is where the flexibility comes in. No one in LSVT Global is telling me that I'm giving every single patient the same treatment. We use the exercises really as a way to teach people what bigness feels like, what effort feels like, how to move their body through space in the correct amount of quote unquote normal amplitude. And then we use that kind of as a touchstone to then work on whatever functional thing they want to work on. I love it because it allows me to make so many changes so much faster in my patients because I'm seeing them so much more frequently. And I'm able to really tap into their reserve. You did your exercises today with me. We did this functional training where we were working on getting up from a chair that has wheels at a desk because that's the only chair you have and you want to use that one. Well, I have to recreate that in the clinic. They have to go home and practice that again. The next day they come in, I get to practice it again with them. So it's kind of happening in real time too. I'm not seeing them once and then waiting 2 weeks to see them again. That consistency of care and that repetition and that insight that I'm giving them in that back and forth is just so wonderful. So I think LSVT Big is the opposite of rigid, and it allows me to be ridiculously creative. And I've come up with so many wonderful dual tasking things that we do, because one of the things that we talk about with LSVT Big is, and in neuroplasticity in general, is once you fix it, you don't just leave it alone, you take it to the next level. So you keep increasing the challenge, the intensity. You know, so where Jessica's talking about having her person try to have a normal volume conversation while they're reaching in the bag, I'm doing the opposite. I'm having somebody practice getting in and out of that chair at the desk while they're talking to their wife over here, and while they're reaching in their pocket here, and while they're turning their lamp on here, and they're doing all of these things together. So it is, I have never done the same treatment twice in any of my patients. And again, a young onset person is going to look much different than someone who is wheelchair bound. And that's the beauty of this program, is it really spans those 5 stages where you can really provide care to these folks. So I'd like to put in a plug also for those late stage. We get a lot of therapists and patients who say, well, I don't need it. You know, early on, I'm doing great. And then you'll get the opposite who'll say, well, these people are sort of at the end stage. It's kind of time to close up shop. There's not much we can do. Those are some of the people that I've had felt like I've made the greatest impact on, because I've given them some opportunity to now do something that they never thought they could do. It may not be that now they're getting up and walking independently, but now their partner doesn't have to strain their back and pull on their arm and do all these terrible movements, whereas they're just knowing how to place their hands and how to cue them and how to talk them through doing it again. So that really is the beauty. So like I said, the only rigidity is the rigidity you find in your patient and within yourself. So you should really take that LSVT and run with it, because it's just an open process for everybody.
I am going to write that quote down and remember that one, Heather. That's awesome. And for those of you that are joining us that haven't gotten LSVT Big certified but are thinking about it, when you take the course, you'll see some of Heather's really fun ideas that may shock and awe you about what she does with her patients with dual tasking and balance challenges. So totally, it's so fun. Cynthia, a short answer, is it the same for LSVT Loud?
Certainly. And I think, you know, when you talk about protocols and you talk about processes in the development of research, that's essential. We have to define what are the elements of treatment that make it successful. And when you're putting these things in randomized controlled trials, you're taking these ingredients, just changing one, comparing it there, say what works better. And that's what allows treatment science to advance. That's the beauty of having the research. And then we have this protocol that has these ingredients, core exercises, core functional components, core hierarchy tasks that focus on amplitude, sensory retraining at sufficient intensity. But as Heather said, I think beautifully, and the exact same thing for Loud, we tailor that to the personal goals of the patient, what they talk about, what they move. And so how that expresses itself can be very individualized within that scientifically based protocol of ingredients that we know work.
Thank you. Thank you so much. And just we have a few more questions here, but for those of you that are joining us, just a reminder, we have about 10 minutes left. So if you have some burning questions, now is the time to type your questions into the chat box so that we can watch for those and hopefully address those before the end of our session today. Okay, next one, Jessica, what about people that don't have PD? Can you use LSVT Loud for other diagnoses? And if so, do you still call it LSVT Loud? Do you still do the same dosage? Can you address that one for us?
Got it, sure. What's been a lot of fun is applying LSVT Loud outside of the diagnosis of Parkinson's with all of these different underlying pathologies. Fortunately, with LSVT Loud, there are a number of research studies starting to show some nice effectiveness of using LSVT Loud for a variety of populations. Anywhere from, and I'll kind of list some of the individuals or families we've worked with, people with voice issues just secondary to age-related changes, individuals with speech and voice issues secondary to cerebral palsy, to stroke, to Prader-Willi syndrome. We work with children, people on the autism spectrum. We've worked with a lot of individuals, people with atypical Parkinsonisms as well. What's really nice is that we do not change the protocol. The protocol remains the same. And as Heather and as Cynthia said, there's so much flexibility within the proven protocol that it's very, for me and for our for LSVT Loud or Big Therapists, much easier to optimize it for that individual that we're working with outside of Parkinson's. So the protocol remains the same. And the only thing that I have started, or that I noticed when working with some individuals, is that I may need a pre-treatment period where we get ready for the intensive protocol. So for example, there was a young man with autism spectrum disorder who came into our clinic and had difficulties with volume and breathing during speaking and intelligibility or speech clarity. And he was not initially stimulable for the program, but he and his mother really wanted it. They really felt like this was something that could work. And so we agreed to try to get him ready to tolerate a 1-hour session with a number of repetitions and trials we needed within each exercise within that 1-hour session for each day or 4 days a week for that month. And with that training period, we were able to get him to tolerate the intensive protocol, and he had some great outcomes. So that was the only difference in applying LSVT Loud for this particular individual, but otherwise we've had some really great outcomes outside of PD.
Awesome. And I think we can say the same thing for LSVT Big, Heather and Bernie. Cynthia, there was a chat question that came in about pediatrics, and you mentioned some pediatric diagnoses in there, Jessica. But if there's someone, Cynthia, that is a pediatric therapist and is interested, how can they learn more?
Yes, I was just typing a little response. So definitely pediatric populations, more advanced and loud. We have publications, even 2 imaging studies looking at changes in these children. So we have a pediatric course that after you're LSVT Loud certified, you can actually take a 3-hour pediatric course to learn how to apply it. But we're creating a pediatric core certification, which will be a 2-day training course just for pediatric clinicians who don't want to learn about Parkinson's, which of course breaks our hearts because we know it all, but we understand, and that will be coming out this fall.
Okay, perfect. All right, we're going to take one last question on our top 10 questions. I think we've nearly gotten all of them. But this one I think is really, really important. And Jessica, you started to answer it earlier about maintenance. We all know that the LSVT protocols are fabulous, have, robust outcomes that have been published. We see it clinically on a day-to-day basis as well. But we know that for all patients, it's not easy to maintain. It's not easy to keep going with their exercises at home, to stay motivated. So what are your best recommendations for your patients after this intensive 1-month treatment is over? And Heather, I'm going to start with you for a quick answer, and then Jessica, a quick answer, and then we'll wrap up our webinar.
You got it. So if you are an LSVT trained clinician, you can do additional training online to become an LSVT Big for Life clinician. And that's a class where, people who have all your patients who have completed LSVT Big, gone through the 4 times a week for 4 weeks, can meet together. Of course, now things are different in COVID. There are plenty of places out there, though, that are offering virtual classes. And again, it is a way to motivate people, to help people have some onus for keeping up with their homework and what they do, for support of one another, for us as therapists to be able to stay kind of in touch with those patients to make sure. And it's just a fun way to keep people going, because again, we can't forget that this is a progressive condition. Things will change over time. And all of us could use a little extra help these days with staying motivated to do things. So I really do think that the Big for Life classes are a great success, whether they're in person or they're virtual.
Okay. And do you ever see your patients again?
All the time. It's a revolving door. Absolutely. Because you see what's going on. Well, I'll tell you, at least in our clinic, if people don't return for a maintenance class, because of course we can't teach enough classes, there's so many people. People leave our clinic and they already know when their next appointment is. We have that ability and that luxury to say, okay, within 6 months, or when do you come to see the doctor again for the next appointment? Okay, you're coming to see us the same time. We happen to be in the same building. So people know that we want to see them again, and this just isn't a once or done. We always talk about it kind of as a chapter in that book of living with Parkinson's disease. This was chapter 1, coming back for chapter 2. We keep going through it. So yeah,
Got it.
once you're with us, you're always with us.
So almost like your, twice a year dental checkups. They just come back.
Absolutely.
Got it. Got it.
Put that in there, Laura. That's a perfect example. Because when we think about the dentist, if we have an issue, we'll go to the dentist and we'll deal with our cavity or a crown or something like that. And when we think about LSVT loud or LSVT big, that's, a patient coming in to get their full dose of big or loud. And then, with the dentist, we have to go in for our occasional checkups and cleanings. And these can be our tune-up sessions, how patients will check in with us or we check in with them. And we say, how are you doing? Come on in, let me check you out. Let's see, make sure you're staying strong. See if we need any other tips. If I have to, if you need a little rev up and a refresher session, that's similar to that dental cleaning. And then, similar to having to brush our teeth every day, that's that home exercise program. And LSVT Loud for Life is similar to LSVT Big for Life in that it's just a great way to stay social, to stay confident with your communication or your movement, and just stay, adherent to those exercises you have to do to stay strong and be heard and live your life well.
Absolutely. And I also, have found a lot of benefit from my patients that maybe they don't have a Big for Life class to go to, but they use the videos, that homework helper videos on a day-to-day basis. That helps as well. For LSVT Loud, you guys have the companion, the software technology that's really wonderful for home practice too. Okay, so this was great. I want to share my screen and just show you a couple of wrap-up slides here. And all right, well, it's not cooperating with me, so hold on one second. We do have a webinar coming up in February on this very topic. And Cynthia, for some reason, my screen isn't sharing, but I can tell you that if you go to our blog, I don't know if you've got, thank you. If you go to our blog, blog.lsvtglobal.com, and you can register for this public webinar next month. It's on Wednesday, February 17th at the same time. And this one is geared more towards patients. So if you're a person with Parkinson's, a caregiver, this webinar is really geared towards you, but anyone is welcome to attend the webinar as well. And we'll be talking more in depth about what are these tips to help maintain treatment gains. So it's free. Be sure to sign up and join us next month for our webinar. And in the last slide, just a reminder, if we didn't get to your question or you think of other questions or maybe something sparked some interest, we have a ton of information on our blog, or we can give you a direct answer via email, and we put our email address and website address on there as well. Reminder to check your email this week for the survey that's coming out. And lastly, I would just like to thank all of our participants for your time in joining us today. And I'd like to thank our panelists in joining us today too. Your insights are just so valuable, and I hope that all of you have enjoyed learning from them, and we'll see you next month. Bye, everyone.